Yes, we can see it.
Oh, perfect. Okay, guys, let's get to it. Okay, so the first important thing with CVP, and this is they're probably going to ask you for sure, they're going to ask you about, is the orientation. Yani, even if they don't ask you about it directly, you need to understand it so that you can memorize and be able to visualize the heart in your brain, okay? So whenever you look at any image of the heart and or model or diagram, you need to orient it. And the proper orientation for the heart and how it's placed in our body is that the apex would be down and out. So it's inferiorly and more to the outside. The anterior interventricular groove would be between the ventricles. So as you can see here, you can see it here. You can locate the interventricular groove just by looking at the vessel. If they show you a vessel, like this picture, for example, if they get you this heart, you'll be able to locate the interventricular groove by just identifying the vessel. And by identifying the interventricular groove, you can tell that, okay, this would be the right ventricle and this would be the left ventricle, okay? Another important thing is the pulmonary trunk and the aorta, okay? So this is just to here. So the pulmonary trunk is always anterior to the aorta. As you can see here, this is the origin of the pulmonary trunk and this is the aorta. And then here as well, the pulmonary trunk and the aorta, okay? So it's always anterior to it. And the aorta is always to the right. So the aorta is always to the right and posterior to the pulmonary trunk, okay? By the way, guys, anytime you have questions, عادي ask, okay? Yani, it's better if you unmute and then ask so that I can hear you. أحسن من ما I check the chat. Okay. So yeah, this is again the aorta. Can anyone, before we get to it, can anyone guess what each number is? What's 8? What part is this of the heart?
Auricle of the right atrium.
Yep. 1. 1 is kind of, yeah.
Aorta.
Yeah, okay. 5.
Brachiocephalic trunk.
Yeah. And 6 and 7.
Common carotid and left subclavian.
Left subclavian and left, I think, carotid.
Yeah,
Common.
left carotid, yeah.
Yeah. Okay. Right. What about this? What is this? Can anyone identify it? This layer.
Is this oh.
Mm-hmm. Yeah, go on. It's a layer. What is this layer called?
Pericardium.
Yeah, but be more specific. If you remember, there's 3 types. صح?
Is it the fibrous pericardium?
Exactly. The fibrous or fibrous pericardium. How did we know it's the fibrous? Because it stretches all the way up here. Okay. The parietal one, here, I'll show you in this next picture. So you can see the fibrous, it goes all the way up. The parietal is more, it's on the inner side and it bends down like this, like a balloon, okay? Or so it's on the inner side of the fibrous, okay? So the fibrous is the one that you see here. It's the one that extends all the way up here to the vessels. Parietal is directly underneath it, and visceral, you can't see it, okay? It's stuck to the heart. Okay, now these are the borders of the heart, okay? شفت حطيت لكم animation وحركات. So who can guess the right borders or answer, I guess? Yeah, you guys should know this by now. The right border of the heart, what is it? Lazim you answer in like less than a minute. These are your OSPE stations will be much less than this. So no one.
In terms of costal cartilages, or what forms the right border?
No, what forms the right border of the heart?
Oh,
yeah.
The right atrium.
Yes, exact. So right atrium and superior vena cava and inferior vena cava. Right atia, I think, come on, answered. Okay, so that's the right border. The left border, I said it, خلاص بينت لكم إياها. It's the left ventricle right here. Okay. What about the inferior border of the heart? What lines or makes up the inferior border of the heart?
Right and left ventricles.
Yep. superior border طيب. Yeah, right ventricle and left ventricle. Okay, Atia. What
Great
about superior?
vessels.
Yeah, great vessels and the right and left atrium. Okay, because you have parts of the atrium here. And finally, the apex.
The left ventricle.
Yeah, okay. Now the surfaces of the heart. So we have the anterior surface. Okay, so the anterior surface of the heart, if you just think of the orientation slide, it's mainly which chamber is mainly in the anterior surface?
Right and left ventricles.
It's mainly the right ventricle. Okay, so this is what you need to remember. No, it's mainly the right, as you can see here, this is how your heart is oriented in your chest. So this is your right ventricle. It's the most anterior part, and it makes up most of your anterior surface. Okay, the base, however, this is the base, the surface that would be back here. So this would be which chamber is this? The left atrium. Exactly, yeah. And then the inferior surface would be the right and left ventricles as well. The pulmonary surface, the right pulmonary surface, so which would be this side. This would be the right atrium. And then the left pulmonary surface is the left ventricle. So the red is the left pulmonary surface and the blue is the right pulmonary surface, okay? They form impressions on the lung and you'll see it when we get there as well. Okay. This is really important, especially, they're gonna definitely ask you guys about the coronary vessels and the coronary arteries. So let's try to label them, okay? So what's this right here? This one, this coronary artery, what is it called?
The left coronary artery.
Yes, and it divides into?
Left anterior descending and left circumflex.
Exactly, yeah. Then we have what's the other one? The right coronary, right? So what does it divide into?
Posterior inferior.
Yeah, posterior descending, you mean? Hadi, it would be in the back, an inferior surface, yes.
Yes.
But first it gives artery here.
Yes, I think it's, I forgot the name. I'm sorry.
Yeah, this is the right coronary artery and it gives off also the SA nodal artery. Hello, we'll see them. Oh, ما في animations. My bad, guys. نسيت أحط animations on this. But okay, so basically this one is the right coronary. You'll see the names when you get the PowerPoint. So this is the right coronary. Here you have the right marginal, okay? Then it goes all the way back and it gives off the posterior descending artery, okay? So do you guys know what this is called? The area, the groove here that wraps around the heart and that the right coronary is running through right now.
The coronary sulcus.
Yes, the coronary sulcus, exactly. One important thing here is that the left anterior descending, it goes down towards the apex and then sometimes in anastomosis with the posterior inferior. Okay, and of course you guys should know the blood supply of what each artery supplies. So the LAD supplies the anterior 2/3 of the septum and the posterior third is supplied by the posterior descending. Okay, so in terms of blood supply for the SA node and the AV node, what are they most commonly supplied by? What artery?
Right coronary.
Exactly, right coronary. SA node, usually I have the percentages here, Mafrood, yeah. Right coronary is in 55 to 60% of individuals, it supplies the SA node. Left coronary, 40 to 45%. The AV node, it always follows the dominance of the heart. So that's why most of the time it's supplied by the right coronary artery because the branch that supplies the AV node comes from the posterior interventricular artery, and whoever supplies the posterior interventricular artery would be the supply for the AV node. And in 90% of the cases, it's right coronary. So here we have a question. So the left coronary artery and its branches supply all the left atrium and the entire ventricle except what? The strip of the left ventricle that's parallel to the posterior interventricular sulcus. So basically this part. in the back on the inferior surface of the heart, the posterior interventricular artery, it supplies some branches of the left and right ventricles. Okay, so that's why it's an exception. Okay, but other than that, the left coronary artery supplies most of the left ventricle and the left atrium, except the part that's parallel to the posterior interventricular sulcus. Okay, coronary dominance. Okay, so for coronary dominance, this is what I just mentioned, min shwaya, and no, basically depends on which artery is being supplied by, which artery supplies, sorry, the posterior descending artery. So we have co-dominance, which is 7%, right dominant 85%, and left dominant in 8% of the individuals. These are the percentages according to Akif's slide. They're kind of different, but yani, I think you just need to know that right dominant is the more common one. Does anyone know the clinical significance of the whole dominance thing? Like, why do we need to know if someone's right dominant or left dominant? Why is it important? Can anyone guess?
In a case of an occlusion in one of the arteries, if it's if the entire blood supply to the heart is coming from the right artery, and not of the entire, but mostly from the right artery.
Which part would be affected mainly? Which part are you concerned about here in terms of
the interventricular septum?
Exactly, interventricular septum. Also, yeah, I see the people in the chat as well. Exactly. So it's basically when there's a blockage of the left coronary artery, they're worried if he's left dominant, then his entire septum will be gone. It can be easily then after that, after getting the MI, if the MI is myocardial infarction is established and everything, the septum can even perforate. But in someone who's right coronary dominant, no, the septum, the posterior third of it, as you can see here, is preserved because it's being supplied by the right coronary. So the septum will be able to compensate because of the blood supply from the right coronary. Okay, so that's why most people are right coronary dominant, and that's why it's actually a good thing to be right coronary dominant. Okay. Now, next. Okay, so this is what I basically just explained. Okay, so now the venous supply. I have a feeling I did not animate this either. Okay, I did. Okay. طيب, now the surfaces. So this surface, I don't know if you saw, but what surface is this for the heart? What is it called? It's the anterior surface, but yani, what does it contact with? What overlies this?
The sternocostal surface.
Exactly, yeah. And the other one is the diaphragmatic surface. It's the one that lies on your diaphragm, okay? Right, now we have the veins. So the veins, what is this big vein right here? You can kind of guess its name from the area it's in.
Coronary sinus.
So this is the coronary sinus. It is a large sinus that drains basically all the venous drainage of the heart. And you can see it has many tributaries, okay? And where does it insert? What chamber does the coronary sinus insert to? This is important.
Right atrium.
Exactly, the right atrium, okay? So what are the three main tributaries that drain blood into the coronary sinus? So basically coronary sinus receives venous drainage from who? Mufrud fi three main veins.
Is it great, middle, and
Small. So yeah, great cardiac vein, middle, and small. Okay, so first of all, this is the coronary sinus. Then we have the great one, which is here, the great cardiac vein. Okay, then we have the, before I mentioned the rest of the great cardiac vein, it's important, if they ask you about it, they'll definitely ask, what accompanies the great cardiac vein. What does that mean? What they mean is that what vessel, what artery goes down or is also beside the great cardiac vein, and that is the left anterior descending, because you can see here, the great cardiac vein begins here in the apex, because veins are opposite to the arteries. Arteries begin from the heart, then they spread to your periphery. Veins are the opposite. They start from the periphery and go towards the heart. So this great cardiac vein, it starts in the apex, it drains all the blood here. It goes up into through the interventricular septum, and then goes around the heart around the left atrium to be specific, and drains into the coronary sinus. So this is the great cardiac vein, and it accompanies left anterior descending. Okay. Next, we have the middle cardiac vein. So the middle cardiac vein is on the inferior surface, meaning it accompanies which artery? If it's on the inferior interventricular groove, it accompanies
posterior, inferior, interventricular
Yes.
artery.
exactly, yes. So it accompanies the posterior inferior artery or interventricular artery. ما بعرف ليش بحكي inferior. But yeah, okay. Then we have the small cardiac vein. So here we have the middle cardiac vein. Then the small cardiac vein comes along and they join. It comes also from the coronary sulcus. It travels from the anterior surface here, goes around to the inferior side. Okay, so it starts from the anteriorly, then goes around to join with the middle and then go into the coronary sinus. So just remember that the small cardiac vein is under the right atrium. Whenever you see the right atrium and then you see a vein and they ask you what's the name of the vein, you think of the small cardiac vein. The middle, it's easy to identify. It's in the posterior interventricular groove. And the great, it's also easy to identify. It's in the anterior interventricular groove. Okay. And yeah, it accompanies the right marginal artery. Okay, so the small cardiac vein accompanies the right marginal artery because yeah, it's on the right side of the heart. And then the rest of these veins, they're low yield. They won't ask about them as much as the three main ones. But yani, I put them here so you guys can know them. Okay, now the anatomy of the right atrium. Okay, so we need to find these things. I have these terms here, or characteristics or features or whatever, right atrium, and you have to tell me which one, basically match the letter to the name, okay? So the bold ones, by the way, are present in both the right and left atrium. So let's start with the interatrial septum. Which letter represents the interatrial septum?
B.
Yeah, exactly. طيب. Pectinate muscle.
E.
Yeah. Auricle.
G.
G. Exactly. Fossa ovalis.
C.
Fossa ovalis, or is it? Yeah, C. Crista terminalis.
F.
F, exactly. Yeah. Sometimes, by the way, in other pictures, they show it to you on this side as well. Okay, so just keep looking at pictures of the right atrium and other and the heart structures, so you're familiar. Coronary sinus, the opening for the coronary sinus. Sorry. If you remember, we said it drains into the right atrium, so it should be here. Can you guys see the opening? Okay, بعطيكم hint. It's here. This is where the coronary sinus drains. Okay, drains into the right atrium. As you let me go. Can I go back? لا ما هيخليني. بس yeah. Okay, هنا this opening, it's the one that's covered by the Thebesian valve. هاي opening for the coronary sinus where the right atrium receives venous drainage of the heart. Okay. And then here you have a valve for the inferior vena cava. And this is something that they might ask you about. But a good thing to know is that the inferior vena cava and the coronary sinus are the only two vessels in the right atrium that have a valve to prevent regurgitation of the blood. Okay, which makes sense since they're in the lower side of the right atrium, while the superior vena cava wouldn't need a valve. Like, where do you think the SA node would be located?
Should be at the foot of the superior vena cava, so A.
Exactly. Or AV node?
AV node would be within the interventricular septum almost.
Yeah.
So
So,
yeah.
So it would be between the coronary sinus and the septal cusps of the tricuspid. So it would be somewhere here, yani.
Yeah.
Basically. Okay. Yeah, that's mainly it for this right atrium. Okay, so these are just.
Can you say again what you mentioned about the crista terminalis?
So in some pictures, they show you that the crista terminalis, they show you a continuation of crista terminalis here. And it's not always labeled just here. So basically, for your imagination, this here, it extends all the way here. And this is all crista terminalis. So the crista terminalis extends from here all the way to here. Okay, that's why in other pictures you might, I think I have a picture here. Yeah. Here, this is what I mean. So they might label it here, for example, just to confuse you, yani, instead of here. So just know, and this is also the crista terminalis. Okay.
Okay, and the the AV node would be between the Thebesian valve and the cusp.
And the cusps of the
valve.
tricuspid.
Yeah,
Yes,
okay.
so it'd be somewhere here.
Okay, thank you.
No problem. Now the right ventricular ventricle anatomy. Okay, so right ventricle, it's known to have, the special thing is that it has 3 papillary muscles, not just 2. So can anyone locate the moderator band? Let's see.
It's I.
I, yes, exactly. What's the significance of the moderator band? Does anyone know?
It diverts blood and it brings signals from the interventricular septum into the wall of the right ventricle.
Exactly. And specifically, how does it transmit the signals? Because it carries what? The right bundle of his.
Yes.
Yeah. And so, yeah, I is the moderator band. Then, or the septomarginal band, okay? Type, where's the anterior papillary muscle?
It's J.
G?
J.
J. Oh, okay, yes. Yeah, J. Anterior papillary. Type, that means posterior posterior papillary muscle.
H.
Yep. Okay. Or inferior papillary, as they call it. More inferior papillary, not posterior. Then one more left, اللي هي septal papillary muscle.
F.
Yeah, it's the tiny one اللي فوق. Yeah. Okay. طيب, trabeculae corneae, or where's that?
K.
Okay.
Yes. Then the anterior superior leaflet of the tricuspid valve. So tricuspid, that means it has 3 cusps. The anterior superior one is which cusp?
Would that be C? Yeah.
Let's see, exactly. What about the septal leaflet? Imagine, visualize how it's oriented. B. Yes, exactly. And inferior leaflet would be this one. So anterior superior, septal, and okay. And you can tell this is the anterior one because we know the right ventricle, the heart is oriented with the right ventricle most anteriorly, and you can see that this is the most anterior part of the valve. And this is the septal when this is the inferior. Okay. So the anterior superior surface of the right ventricle, as we said, it occupies the majority of the sternocostal surface. And the inferior one is the diaphragmatic surface. Yeah. Okay. These are other terms that you can look at. Supraventricular crest,
I have a question. What's the difference in function between pectinate muscle in the atria and trabecular carne in the ventricles?
From what I remember, I think it was the to withstand the pressure or the contraction. Like that's what I read when had, but I'll make sure and actually send you an actual thing because I don't want to أتفلسف بصراحة.
That's for trabecular carne, right?
Yeah, I think it was to withstand the high pressure and like be able to, because the trabeculated muscles, they need to come up with like a high enough pressure for the for systole, and at the same time the papillary muscles, they need to be strong enough as well to keep the cusps close, so it works together. But to give you a more scientific answer, I can I'll let you know later.
What about the pectinate muscle in the atria?
The pectinate, I remember, I think it had to do something with the volume. I'm not sure. صراحة ما بدي like I say something بعدين هذا.
Okay.
Yeah.
Okay.
But I'll let you know once I find the answer, okay?
All right. Thank you.
What did they bring up, did they ask you guys about this specifically before? Well, you don't know. Well, you just thought of it.
I'm not sure, but I just wanted to ask.
Okay. Okay, ماشي خلاص. I'll let you know. Okay. Then left ventricle anatomy. Okay. So here again, you have here you have two papillary muscles only. Why do we only have two papillary muscles here? Can you guys guess?
Because it's a bicuspid valve.
Exactly, because the mitral is bicuspid. Okay. Then so we have the only anterior papillary muscle and posterior papillary muscle. So where are they here?
F and I.
Exactly. So F would be which one? Anterior or
F would be
posterior?
anterior.
Yes. So I would be posterior.
I
And
would be
according to the sources command that I read, these papillary muscles, they're thicker and stronger than the ones in the right ventricle. And that makes sense because we know that the left ventricle reaches very high pressures during systole. Do you guys know or remember what the pressure is during systole bil ventricle? Left ventricle. This doesn't have to do with OSPE, but it's good for CVP to know.
Is it 100?
120.
120.
Yeah, it reaches 120 max. Okay. Unlike the right ventricle, which if I'm not mistaken, it's 25, the highest one. But make sure كمان يعني. But I know the left ventricle, it can reach up to 120. Then the chorda tendineae. Okay, so where's the chorda tendineae here?
G.
Yeah. And what's another name for the chorda tendineae? Do you guys know? More of a standard name or common name. Like what people, it's like a non-medical name, yani. Just different. No one knows. It's they call it the heartstrings. They call them the heartstrings of the heart. Or strings of the heart, yani. So that's the chorda tendineae. Okay? If these chorda tendineae, if something happens and they get teared, what can happen to the valve? What will they have? Or if the papillary muscle gets infarcted and it ruptures, what can they have?
Blood regurgitation.
Yeah, so they'll have mitral regurgitation. Okay, you guys talk about mitral regurgitation?
Yes.
Yeah, okay, that's something to remember. Good. Type. Okay, so then the chorda tendineae, then the left atrial appendage. Where's the left atrial appendage?
It's A.
A. Okay, good. Aortic valve. Can you guys find the aortic valve here?
C.
Yep. And what's something special about the aortic valve? How is it made? Like what constitutes the aortic valve?
It has 3 cusps.
Yeah, it has 3 cusps.
And each cusp, the right and left cusps has openings for the right and left coronary arteries.
Exactly. Yeah, that's an issue that you need to know. And they're right, left, and posterior. Yeah. Then for the mitral valve, you have the anterior leaflet and posterior leaflet. I think this is pretty obvious, Sarat. This is the anterior and this is the posterior. So these are the, okay. But now the openings and orifices of the heart. This should be really easy, يعني. The superior and superiorly, what opens superiorly into the heart? At the superior part of the heart, what openings do we have? We have the superior vena cava, صح? Which opens into what?
Right atrium.
Aorta.
Left ventricle.
Pulmonary trunk.
Right ventricle.
Inferiorly, the inferior vena cava opens into?
Right atrium.
Okay, and then posteriorly, what opens into the right atrium posteriorly?
The pulmonary vein.
Right atrium. Pulmonary veins would open into the left atrium.
Coronary sinus.
Exactly, yeah. هذا trick question هيك حبيت أخليه شوية صعب. Okay. So عندنا the semi-lunar valves now, as you guys mentioned. So عندنا the aortic and pulmonary. So أول إشي, which one is this? Is this the aortic valve or aorta or ولا pulmonary? Can anyone find out? I'll tell you how to find out. بس إنه يعني down aortic, upper. Yes, exactly. One key thing to remember, you can see the openings to coronary arteries. And other than that, let's say this isn't clear. If you see this fibrous meshwork, The pulmonary is not associated, is not connected to the mitral and tricuspid with this fibrous network. Only the aorta is. Okay, so this is one way you can remember it, that these three, they're more closer to each other and the pulmonary is more anterior. So this would be the anterior surface of the heart. Because we, as I mentioned Karan before, the pulmonary is anterior. Okay, and aorta is always posterior. Okay, and then we have the cusps. Yeah, we said in right, left, posterior for the aorta, and for the pulmonary valves, you have right, left, and anterior. Okay, you guys, mashallah alaikum, you guys know this also. Okay, now this, yeah, an important one here. Okay, so this is the diaphragm. صح? What do we know about the diaphragm? We have to, important things that we need to label. Okay, so first of all, what is this? The bright part in the center. So this
The
bright
right dome,
no, this bright part in the center هذه كلها
the
إيش؟
central tendon,
Yeah,
central
the
tendon.
center. Yeah, the central tendon, exactly. And here we have multiple attachments for the diaphragm. So this attachment is called what? You can kind of guess from what it's attached to. The
The
anterior,
sternal attachment,
exactly, sternal attachment. Then here, these would be called the,
the cruise of the diaphragm,
yes, and they're attached to the vertebrae. Vertebral attachment, yes. Then we have hina, the diaphragm, this part of the diaphragm, they're called the costal. They're the costal attachments, okay? And then we finally have the central tendon, okay? So here I have them, and we have three openings, the vena cava or caval hiatus, the aortic, and the esophageal. So help me identify them. Which one is this? Which hiatus? It's the aortic, exactly. And what about this one?
the esophageal hiatus,
Yes. And the last one above it?
the IVC.
The IVC one, exactly. So if you notice, the IVC one is in the central tendon. Do you know why is that? Yani, subhanallah, it's convenient for us and the IVC is there. It's actually a good thing. Okay, so do you guys know why?
To prevent its constriction during diaphragmatic contractions.
Exactly, yeah. Because we know the venous system, which includes the IVC, SVC, all the veins, their pressure is much lower than the aortic system, or arterial system, basically. So that's why it can easily get contracted. But the aorta, no, it can't get contracted because it usually has a very high pressure. Okay, so this is central tendon, sternal attachment, vertebral, caval hiatus. Okay. Now we have these openings. Okay, so it's very important to know I don't know why the animations are like this, but okay. You need to identify which one again, but now it's on a cadaver, okay? So can you guys identify which one's the aortic, which one's the esophageal, and which one's the inferior vena cava? So A is which one? Which opening?
The caval opening.
Right, it's caval because it's again in the central tendon and it's at level T8, so it kind of makes sense. Okay. Then the B, that means B would be the
Esophageal
yes at T10, and then C
would be the aortic.
exactly, yeah, and it's at T12. There are many ways to memorize this from a brief mnemonic that I just read. I remember they're like vena cava has 8 letters, so T8. Esophagus has 10 letters, so it's T10. And aorta, it's the only one left, so it's T12. Okay.
There's a better one. It's I8, 10 eggs at 12.
Exactly. Yeah, I remember this one, by the way, in first year. But بعدين خلاص, once you reach fourth and fifth year, you forget all these things. But yeah, this mnemonic كمان I remember it. اللي هي 10 eggs was I8, IVC 8, T8, or 10 T10 eggs for esophagus. What was the last one? 12 for aorta. Do you remember? إيش كانت في النمونيك at 12 at 12 okay. Yes, at 12. Nice, nice. Okay, كويس. أهم إشي you guys you remember the mnemonic وتحفظوه, because I'm pretty sure they ask يعني about, they like asking it. Even if it's not first year, they'll ask you about it later. And know what accompanies each structure. IVC is accompanied by the right phrenic nerve. Right phrenic nerve supplies what?
The right dome of the diaphragm.
Exactly, yeah. And then the esophagus is supplied by the vagus nerve and esophageal branches of the left gastric artery. Okay. So it's accompanied by the vagus nerve and the esophageal branches of the left gastric, and the aorta is accompanied by the azygous vein and the thoracic duct. Do you guys know what this thoracic duct is?
It's a lymphatic. It's for lymphatic drainage.
It drains most of the lymphatics on the, if I'm not mistaken, the right side of your body. Yeah. Okay. But this is important tip. I think I asked you this already about the IVC and why it's in the central tendon. Okay, now the echoes. Okay, so you have the echocardiogram. You have two types, the transesophageal and transthoracic. Okay, so transesophageal, as you can see, it's horrendous to look at بصراحة, and it obviously needs anesthesia and it's harder to do, but it's better. Like its quality is better than the transthoracic. The transthoracic is the easy one, and it's the one that's used يعني more commonly. What was the other name for chordotendinae? It's not really a scientific name. It's just small. It's just a name that they usually call it by, which is heartstrings. Yeah, they call them the heartstrings. Isn't thoracic duct on the left side? I think it is بصراحة. That's why I'm not sure. I just know it's with the aorta. Thoracic duct. I know it drains most of the GI tract. So yeah, I think it is on the left side, actually. Yeah. And it drains most of the abdominal organs and everything. That's why if you have any cancer in your GI tract and everything, it can metastasize to your through your thoracic duct. Okay. But yeah, back to CVP. So here we have the transesophageal and transthoracic echo. Okay. This one, I don't think they usually ask much about it other than just one picture, and you just need to memorize the view. So let's see if you guys know the views. We have three views. We have the apical, subxiphoid, and peristernal. This view right here, do you know which one it is? If it's the apical, subxiphoid, or peristernal? Okay. So basically, the apical view, it's the one that shows the ventricles superior to the atria, because exactly, it's the apical view. It flips the heart, okay? And other than flipping the heart vertically, it also flips the heart horizontally. So that means, anything on the left is actually the right side of the heart. So this is the left, right, of the image. But in the heart, this would be the right side of the heart. So this is the right atrium, and this is the right ventricle. And here, this is the left ventricle and left atrium. Okay, and this is the apical view. So let's see here. Can you guys label this? What's A?
Right atrium.
Okay, and B?
Is
Right
ventricle.
ventricle.
Okay, what about C and D? It's obvious now. No ventricle, left ventricle, left atrium. But okay, now E and F. What's E first?
Mitral.
Tricuspid valve.
Tricuspid.
Tricuspid and mitral. Okay, so just familiarize yourself with images like these, okay? Important tip. What's the important tip? Okay, yeah. In mitral valve stenosis, the valve is stiff, and it will result in left atrial hypertrophy or left atrial dilation. What do you guys think? If the mitral valve is stenosed, so it's narrowed, what will happen to the atrium? You guys took mitral valve stenosis, صح?
Yes.
Yeah. No, it's not hypertrophy, actually. It's dilation. So aortic stenosis, it would cause hypertrophy of the left ventricle. But in mitral valve stenosis, it would cause dilation. Okay, does anyone know why though? Or can anyone guess why it would cause dilation and not hypertrophy? What happens when the mitral valve becomes narrowed? What happens to the blood? It backs up, صح? It backs up all the left atrium. So none of the blood is going to go to the left ventricle. So the left atrium is accumulates in blood and it's forced to dilate. Okay, and it eventually backs up all the way to the lung. So usually it causes dilation. And one special or unique symptom that someone can present with is that they can present with dysphagia, okay, which is difficulty swallowing. Why? Because the left atrium dilated so much that it's compressed the esophagus. And if you remember, بالheart, the left atrium here, it's the base of the heart, right? It's at the back of the heart and it's in front of the esophagus. So it can compress the esophagus when it's dilated and then lead to difficulty swallowing. So this is something that actually not many physicians even think of when someone comes to them with difficulty swallowing, but it's something important to remember. Okay, now the thoracic cage. Okay, so we have the sternum here, and you're just gonna help me fill in the blanks. So we have the three parts of the sternum: manubrium, body, and xiphoid. Manubrium, you'll see here we have a jugular notch. Then we have the clavicular fossa that forms the sternoclavicular joints. Here we have a joint between the manubrium and the body. Does anyone know what it's called?
Manubrio-sternal joint.
Yeah, and it's there's a significance for it.
It occurs at the level of T4 and it's called the angle of Louis.
Yeah, angle of Louis or sternal angle. Yes, that's what they want to know. And it helps. Why is it important? Because it helps with counting. It allows you to count the ribs. Because this part you can even feel it right now on yourself, the jugular notch. So you start here, then you go down, you'll eventually feel a bump, which is the sternal angle. Then beside that angle is the second rib. So that's how you can start counting the ribs, starting from the sternal angle. Type. So now in terms of the manubrium, it articulates with who? Here, I already mentioned one, the second rib. It articulates with the first half of the second rib and the first rib. Okay, so the first rib and the second rib. Yes, as well as the clavicle. Good job. So first rib and second rib. The body, it articulates with the sternum superiorly, with the manubrium. هاي المفروض تكون manubrium, by the way, superiorly, and xiphoid inferiorly. Okay, and the facets on the sides are for articulating with which ribs? Do you guys know which ribs articulate with the body? Let me see chat. The true ribs, exactly. Which ribs? 3 to 6. Yeah. 3 to 6 and half of ribs 2 and 7. Okay. I think, wait, let me. 3 to 9. I don't know why my source said 3 to 6. Wait, هنا 2, 3, 4, 5, 6. Yeah, but then 7, half of 7. I think the rest, they're the ones that join, if I'm not mistaken. Yeah, 8 to 10, not 3 to 9. Because 8 to 10, they all join together and they form one costal cartilage. Okay? And they attach in the end. طيب. So that's mainly it for this one. I don't think they'll ask you about this. If anything, they'll ask you about the ribs more. So we have the typical ribs and the atypical ribs, okay? The typical ribs, they have the main features, which are the head, neck, tubercle, and body, okay? The head, it's usually wedge-shaped and has 2 articular facets, okay? The superior facet, which articulates with the vertebrae above. So for example, let's say this is rib 5, okay? It has here in the head portion, it has 2 facets. This facet, okay, would articulate with T4. Sorry, it would articulate the vertebrae above. It would be, T4. And then this one would articulate with T5. Okay, so in your back, in your thoracic spine, you have T4, then T5. So T4 would articulate with this facet of the rib, of the fifth rib, and then T5 would articulate with this facet. Okay, remember this is in typical ribs. Then you have the neck. Neck, nothing is significant in it other than there's a tubercle between the neck and the body. This tubercle articulates with the corresponding vertebrae. And when they say corresponding vertebrae, again, this means that if this is rib 5, then it articulates with T5, okay? That's what they mean when they say corresponding. So yeah, and it articulates with the transverse process of the corresponding vertebrae except for ribs 11 and 12. That's why they're atypical ones, and we'll get to it. The body is flat and curved, and the inferior part of the surface has a groove, which is called the costal groove. This is the important part in most ribs. So what is the significance of this groove? What does it contain?
The neurovascular bundle.
Exactly. And that means the neurovascular bundle is on the lower border of every rib. That's why whenever they do any surgery, they want to do a cut, make any section in the thorax, they would approach from the upper border of each rib. And they always avoid the lower border of the rib, okay? Because they don't want to injure any of the vascular structures or neurovascular structures running through the groove. So what are the atypical ribs? Does anyone know the atypical ribs? So we have the first rib, the second rib, and 10 to 12. So 10, 11, 12. Okay. Hello, so the first rib, it's shorter and wider than the other ribs. That's one thing that makes it atypical. It has only one facet for articulating with the corresponding vertebrae. So this is the first rib. You can see here, it only articulates with one facet, okay? It doesn't have two facets like the other ribs. And it has two grooves on the superior surface, which make way for the subclavian vessels, yeah. Rib 2, it's thinner and longer than the first rib, and you can see here how it's thinner and longer. And it has roughened area where the serratus anterior originates, okay. Rib 10, the special thing about it is that it has only one facet again, just like the rib 1 for the corresponding vertebrae, okay? So this is rib 10 right here. It has only one facet as well. And rib 11 and 12, they're atypical because they have no neck and they have only one facet for corresponding vertebrae. And they're considered the floating ribs, okay? Because they have costal cartilages in the end, which merge with the muscles of the abdominal wall. As you can see, they don't merge with the rest. Okay, so they're considered the floating ribs. Okay, now the true ribs and the false ribs. The true ribs are considered the first 7 ribs, which connect anteriorly to the sternum by their costal cartilage. So each one independently connects to the sternum by their own costal cartilage. But ribs 8 to 10, they all merge into one costal cartilage, then connect to the sternum. And that's why they're called the false ribs. Thoracic vertebrae. Okay. Am I going too fast or is the pace good?
It's good.
Okay. خلاص. طيب عندنا the vertebral body. For the thoracic vertebrae, 3 things you need to know. Vertebral body, transverse process, and spinous processes. Vertebral body, it's kind of heart-shaped. They have demi-facets on each side of the vertebral body. So you can see this is a demi-facet. So it's demi-facet, yeah, it's not a complete one, it's half. Okay, because it articulates with 2 things. Sorry, because that means the other half is on the vertebrae above it or below it, okay? And it articulates with the head of the corresponding rib and the rib below it. Okay, so here it articulates with the corresponding rib. Here it articulates with the rib below it. Okay, just like we mentioned Menshwai, rib 5, let's say this is T4, or let's say this is T5, sorry. Here it would articulate with T5 would articulate with the rib 5 and rib 6, okay? So rib 5 here would articulate with it, and then here would be rib 6, okay? The transverse processes, you have costal facets on transverse processes, which are here. This is the costal facet, and it articulates with tubercles of the ribs, which I showed you, the tubercle, which is the part here between the neck and the body. And this is present, as I mentioned, in only T1 to T10, because T11 and 12 do not have these tubercles. Finally, the spinous process, it's the special thing in thoracic vertebrae is that it's downward, okay? It slants, it's long and it slants inferiorly, which is actually protective for the spinal cord. So these are some exceptions to the thoracic vertebrae. You have T1, it has a complete facet instead of demifacet superiorly. So here, instead of it being a half demifacet, it has a complete one, and it articulates with the entire head of rib 1, because we said rib 1, it only has one facet. Inferiorly, it has a demifacet, however, that articulates with the superior part of rib 2. For T10 to T12, it has only complete facets on the body or on the sides of the bodies for articulation with the entire head of the corresponding rib. Because again, we mentioned T10, 11, and 12, they only have one facet. So they'll only articulate with the ribs, I mean, T10 to 12. They'll only articulate with one vertebrae. Okay, now the lumbar vertebrae. So lumbar, main thing you need to know about it is that it's kidney-shaped. So the important parts of these, the vertebrae, is just that you can recognize it in case they put it on one of the stations, usually, and they ask you what it is. You'll know, and okay, this is lumbar, mainly because of the kidney-shaped body. For thoracic, it's mainly, you can tell from the long spinous process and the heart-shaped body, as well as the facets. I don't know if they ask any more details than that, but usually not. For the lung structure, okay, so now we're done with the thorax. For lung structure, it consists of apex, base, surfaces, borders, and lobes, okay? So the apex of the lung, it's a blunt superior end of the lung, and it's above the level of the first strip, okay? It rises very up, so it's near the thoracic inlet, okay? The base would be the inferior surface of the lung, which sits on the diaphragm, and the surfaces, they correspond to the area of the thorax they face. So do you guys know what the surfaces of the lung are? There are three main surfaces, yeah.
Mediastinal, coastal, and diaphragmatic.
Exactly. Coastal, mediastinal, and diaphragmatic. So coastal, from its name, it's the part of the lung that faces the ribs. Mediastinal is the surface that is in contact with the heart and mediastinum, basically. Diaphragmatic is the surface that's in contact with the diaphragm. Type the borders, which are basically the edges of the lung. What are they? We have three main borders: the anterior border, posterior border, and the inferior border. Okay, Hala will visualize them. Okay, so you can see here, this is the costal surface. This is the anterior border. Okay, inferior border, and then the posterior border would be the curved part that's out here. One way to remember so that you can orient yourself when you see the lungs in the station, let's say that you have it in one of the stations, the anterior border is always the thin part. It's always thin. You can see how thin it is, okay? It's not like the posterior, it's thick and bulky. And that's because we know, the heart lies here in the anterior part, in the middle, sorry. So the anterior border has to be very thin so that it doesn't, so it can accommodate the heart. And that's how usually I remember it. And now we'll go into depth more about it. So let's see. Let me start with, so can you guys, let's start with A. Okay. Wait. Yeah, right lung, left lung. Okay. Do you guys know what A is? Identify A.
Superior lobe,
Superior lobe of which lung?
the right lung,
Yeah. And so B?
the middle lobe of the right lung.
Yep. And C would be the lower lobe. Type. What about the red and green arrows?
These would be the horizontal and the oblique fissures. So the red one would be the oblique one, and the green one would be the horizontal fissure.
Exactly. And in the left lung, what is the yellow? The yellow is which? It's which fissure?
Oblique fissure of the left lung.
Exactly. And the pink? arrow
The
points
yellow
at,
would be the oblique.
it points at the apex, right? Okay, now this is at the right or left lung?
Left.
Left. Yeah, and how did you know?
Well, first look because of the lingula,
Mm-hmm.
and also
yeah.
the organization of the vessels. I think for left lung it was bronchus first, or was that the right?
If
Not
I'm
sure.
not, it's I think it's pulmonary artery, bronchus, then I have a picture for it coming up.
Okay.
But yeah, هنا it's artery, then the bronchus, then the veins. Okay. But ABV left, BAV right. Yeah. So ABV is for the left lung, which makes sense. Pulmonary artery, bronchi or bronchiole, and then the veins. And BAV for the right lung. Nice. But one way how I knew it كمان is from the oblique fissure. So the oblique fissure of the left lung, it goes from outside to inside like this. That's how I remember it usually. And also, like you mentioned, the lingula. And you can tell also from the arrangement if you're familiar with it. Okay, so that means this would be which lobe? The G.
Superior.
Yes, type. I'll ask about the important ones. F. F is what border?
Anterior, also mediastinal surface.
Exactly, mediastinal surface. And this entirely shows the mediastinal surface. And this would be the anterior border. Exactly. That means this border, H, is posterior. This would be the diaphragmatic surface. Yeah. I think this is the oblique fissure. We mentioned it. Yes, this is the left pulmonary artery. Okay. And the cardiac notch. This is important to remember. In the cardiac notch, it's in the left lung. Okay, and it's for the heart, to accommodate the heart space. Okay. Now this one, is it right or left?
This is right.
Yeah, it's the right lung. Okay.
I used the Fisher method that you just mentioned. Left lung. Yeah.
Exactly. Yeah, that's how I خلاص know it now. In the right, in the left, usually left lung, it's from the left side to the right side down like this. In the right lung, it's like this. And especially since here you can't really see the middle lobe clearly, you know, so it's confusing. طيب, so what's F? Wow, you can draw it. I didn't know that. Oh my God, that's so cool. I feel like a gram, but yeah, this would be the middle lobe. طيب, so what, can anyone guess what F is?
Would these be the pulmonary arteries?
No. F, if you remember what we said with the left lung here, it's ABV, artery, bronchus, vein. In the right, it's the bronchus. Then what? So F is the bronchus, then these would be what?
The arteries?
Yes, and then vein.
The veins. Okay.
Okay.
I have a question. If they are going to ask us about the hilum, how would they ask us about it?
I think if they do ask, maybe they'd ask about يعني, you know, they'd label يعني, like they'd put a pin on something, like they could put a pin on this and tell you, what is this? Okay. Or same thing with any of them. That could be one way they ask.
Yeah, that's what I mean. Would it be hard to tell if I'm supposed to answer with hilum or the name of the vessels? Like, is that a point of confusion for the answer, or should it be clear?
You mean, okay, so if they ask about it and then you just say hilum, and you want to know if you should be more detailed or just say hilum, is that your question?
Yeah.
Okay, I think in these type of situations, just write whatever you know. So يعني if he's pointing to this, I would be like, okay, the F is pointing to the bronchus of the right lung in the hilum. You get me? So يعني basically explain as much as you can just to show that you know. But I think usually if they want you, actually I don't know. They might want a specific artery. You can, if they pinpoint one artery, then say the name of the artery, and just like I said, say in the hilum, just to be safe. You can also look at recent files, يعني, to make sure. But yeah.
Sorry, I just had to ask because I heard the story. They would put a pin on the cardiac notch, but it was so far from it, and they were confused on what to answer. So, yeah,
they would put a pin on the cardiac notch here. And they would,
from what I understood, that the pin was kind of far from it, but the answer was supposed to be cardiac notch. So
yeah, that's weird. Because cardiac notch, if it's cardiac notch, then they would have to put it like somewhere in this area, I think. If he puts it anywhere near the vessels, I'm pretty sure that means he wants you to say the hilum. I know this is the hilum of the lung. So yeah. How do I erase this عشان we can this is so cool. طيب, now important tip again. So the ligament around the hilum has a dead space recess, which is useful for what? Does anyone know?
For when the vessels are distended, so they have space for dilation.
Close, but it's basically same concept, but in the bronchus or the bronchial dilation, because our bronchioles, they can dilate just like our blood vessels and constrict. So whenever there's increased demand for oxygen and you need to increase airflow, you need space for bronchial dilation. So that's why we have that space. Haneen, regarding how to differentiate the right to left. So في multiple methods. If you see a cadaver and the lingual is of obvious like this one, you'd know it's the left lung. Another thing is what I use is I would look at the orbital fissure. If it's going from left to right like this, then I know this is the left lung. Okay. Also, I would look at the anterior border. The anterior border is usually thin. Okay, so I can, it helps me imagine, okay, so this is the posterior border, this is the thin anterior border, this is probably the left lung, okay, as well as the orbital fissure, okay. For right lung, again, same thing, this would be the anterior border, this is the posterior border, so this must be the right lung, and you can look at the orbital fissure as well. It goes from right to left. This is how I remember it, yani. And the more you look at images, the more it helps, yani. So yeah, the left lung, basically orbital fissure goes from left to right. Right lung, the orbital fissure goes from right to left. Okay, and it goes down like this. Okay, I hope that clears it up. Now, okay, now the lung impressions. So, again, this is which heart? Yeah, sorry, which heart? Sorry, which lung? This is which lung?
Left lung.
Yes, exactly. See, so orbital fissure from left to right. So this is the left lung. Okay. And what impression do we have here?
The aortic arch.
Yes. And then here?
The descending aorta.
Yep. And finally here?
The heart, the apex of the heart.
So it would be, if I'm not mistaken, it's the left ventricle. Yeah. Mainly the left ventricle. Okay. Then here المفروض كان يعني أبين لكم other هذا هنا. But basically here, this would be again, this is the right lung. Okay. So here, what impression is here? What organ goes here?
The azygous vein.
It's the esophagus. Here, it's the esophagus. Okay. Azygous vein, I think it's here, if I'm not mistaken. Okay. So it's esophagus. Here's the azygous. Here we have something that I didn't see written in your lab material, but it's basically the trachea. Okay. So here we have the esophagus, the azygos. طيب, what's B? Does anyone know what B is?
Right brachiocephalic vein.
B is right, yeah, brachiocephalic vein, exactly. That, and then C.
Superior vena cava.
Yep. D.
Also cardiac compression.
Yeah, and which part of the heart mainly?
Right atrium.
Exactly. And that's pretty much it for the cardiac compression. Okay. Okay, so now Abdulaziz will be continuing with the remaining. So let me, he's going to share the screen, okay?
Okay, just let me share my screen. Okay, can you guys see my screen?
Yes.
It's clear?
Yes, it's clear.
So, assalamu alaikum everyone. My name is Abdulaziz Alaklabi, and I'll be continuing off from where Rawan left, inshallah. So again, like Rawan was doing, we'll try to keep this interactive. So I'll be asking a lot of questions, and try to unmute or write your answer in the chat as we go along. So to start off, inshallah, we'll be talking about the mediastinum. First, we're going to talk about basic definitions and basic contents of the mediastinum, and then we'll go over a lot of cross sections, and we'll identify different organs, inshallah, in the different cross sections. So to start off, as we know, the mediastinum, I want to talk about the divisions. So the initial division, we can divide it into superior and inferior based on a single land point. Does anyone know what this is? What separates the superior and inferior mediastinum? So basically what separates the, yeah, go ahead.
T4, angle of Louis.
Yes, yes. So T4, the angle of Louis, is what separates the superior from inferior. Okay. And the inferior is further divided into 3 separate compartments, which is the anterior, middle, and posterior. Okay. So for the superior mediastinum, the borders are from the superior thoracic aperture to the T4, as we said. So anything above T4 all the way till the thoracic aperture is the superior mediastinum. So here, the main contents of the superior mediastinum in relation to your exam will be the veins, the left and right brachiocephalic vein, which we'll see on cross section how they join to make the SVC. Sorry, this is a mistake. The superior vena cava, and we'll see that again. To identify which vein it is, it'll look like it's coming at an oval shape at an angle as it's joining with the right brachiocephalic vein and making the superior vena cava. Second of all, you're going to see the arch of aorta. So you're going to see the arch of aorta along with its 3 branches. And this is all above T4, remember. So this is included in the superior mediastinum. So you're going to see these 3 branches, which are the brachiocephalic trunk and the left common carotid and the left subclavian. And then most posteriorly, you're going to see two structures in almost all of them. All the cross sections will be the trachea and the esophagus. Okay. So again, the trachea, the key points about the trachea is that it's always posterior. It's always posterior to the heart. And if you see the trachea, this means that you are above T4. Why is this? Is because at T4 is when the bifurcation of the trachea begins. So if you see the trachea, that means you're above T4. If you don't see it, now you know you're below T4. Could be T5 or lower. And then another point is the vagus nerve. Okay. The vagus nerve, which you'll not see on cross-section because it's pretty difficult, to be honest, to see. However, in the cadaver, you will see that it will be very close to the heart and giving a branch, which is the recurrent laryngeal nerve on the left side of the heart. So on this cadaver, we can just see and point out main structures, to be honest. Main or key features that you should know are the nerves. So we can see here, this is the phrenic nerve, and this is the vagus nerve. So as we said, the vagus nerve runs really close to the heart and gives a branch, which is the recurrent laryngeal nerve. And then I think, mashallah, Rawan already covered most of these, but we'll go over them shortly. So this is going to be the left subclavian artery. This will be the left common carotid. This we can see is going from left all the way to right, crossing over is the left brachiocephalic vein, which will join with the right brachiocephalic vein and create right here the superior vena cava. And then lastly, we have the brachiocephalic trunk. Okay. Now, continuing off from the superior mediastinum, we're going to talk about the inferior mediastinum, which is again is divided into three compartments: the anterior, middle, and posterior. So the anterior, which is the smallest compartment, is essentially anything posterior to the sternum itself and anterior to the pericardial sac. So mainly all you're going to see is the thymus, if you guys know what the thymus is, and some thoracic vessels, internal thoracic vessels. That's pretty much it for the anterior mediastinum. The middle mediastinum is where you'll see the heart, the entire heart, the great vessels, and different nerves and additional vessels as well. Posteriorly, which is posterior to the pericardial sac and anterior to the vertebra, you're going to find the esophagus, the azygous vein, descending aorta, vagus nerve, sympathetic trunk, thoracic duct, trachea, and the intercostal vessels. So you're going to see all this in the posterior segment or the posterior compartment of the inferior mediastinum. And we'll identify all of these structures, inshallah, on cross-section as well. So initially, before we go and cover the cross-section, we'll try to cover this cross-section first of all. So can anyone guess what level we are at right now at this cross-section?
Below T4.
Below T4. And what makes you say this?
Because the trachea isn't visible
Perfect.
as a whole.
Perfect. Okay. That's excellent. So a very key landmark, as we said before, is if we see the trachea or not. And then we know if we're above or below T4. Okay. What else do you see that maybe also hints you toward a specific location or level? Does anyone know what the structure F is? Okay, so we'll cover all this inshallah. This right here is the pulmonary trunk giving the branch, which is the right pulmonary artery. So this bifurcation of the pulmonary trunk and giving us two branches, which you can see, this is the continuation of the left pulmonary artery. The bifurcation is at level is T5. So again, the land points that you see is that there's no trachea. Instead, we see two bronchus, which is left main bronchus and right main bronchus, A and E. So we see this, we know we're below T4. And what else do we see? We see the pulmonary trunk divided into two. That means we're at level T5. What else do we see in this picture? We see G and D. This is the ascending aorta, and this is the descending aorta, okay? Because we know the aortic arch will loop posteriorly and descend into, past the thoracic cavity into the abdominal cavity. And then we can also see H, which is the superior vena cava. And B will be the azygous vein, and C will be the esophagus. So inshallah, we'll go step by step to further, cement this in your brains. But this is just kind of just like a brief summary, first of all, to see what you guys know. So basic kind of knowledge in the cadaver. There's not much to cover here, but very specifically, you always want to be aware of the phrenic nerve. They'd like to ask about this specifically on cadavers. You should know the order of the intercostal vessels from VAN or VAN, the vein artery nerve. Okay. You can see the arch of aorta right here, and of course the heart is not present. You want to know the esophagus, they may ask this, and the descending aorta, which we can see. And specifically, we can see the left vagus nerve again, which is giving off the branch of the recurrent laryngeal nerve. So this is what you should know. As well, here we can see the azygous vein and the arch of azygos, and it's draining into the structure right here, which is the superior vena cava. As well, we can see right here, this large vessel is the thoracic aorta. And right beside this tiny little structure, which is barely visible, is right here, is the thoracic duct. Okay. Okay, now, so we're going to begin with the cross sections. Okay. So to start off, I'm going to give you guys pictures of what level we're looking at from an anterior point of view, so you guys can kind of visualize where we're going. So this yellow line right here is the cross section that we're going to be looking at. So as we can see, it's going to cross multiple vessels. So initially it's above the lungs, and the heart is not involved, of course. We can see it's crossing through this blue structure, this red structure, and this blue structure, and as well those other red structures. So what we're going to see mainly at this view is the vessels, the right and left brachiocephalic, as well as the three main branches of the arch of aorta. So when we look at this, I want you guys to, we're going to identify each structure, and we'll go and see the labeled image after this. So can someone answer me, what is this vessel right here, or this structure right here?
The trachea.
Trachea, nice. What makes you say, how do you know it's a trachea?
Because it's big and the esophagus is right behind it.
Exactly, yes. Another point that you can see is you can see this cartilage. You can see this cartilage is covering the trachea, and it's not present posteriorly. You see how posteriorly, the trachea is more circular anteriorly, and it's flat posteriorly. This is because the cartilage is only present anteriorly, and is not present posteriorly. And again, as you said, you can see the esophagus posteriorly. And the esophagus may look different in other sections, but yeah, so this is the trachea and this is the esophagus. Does anyone know what these two structures are?
Right brachiocephalic.
Yes, so this is the right brachiocephalic, and this is the left brachiocephalic. And you see the difference is that when you're doing a cross section, if the vessel is coming at an angle, you will not see a circle, you'll see kind of like a loop. And this is because it's not coming posteriorly or descending completely downwards, it's coming at an angle. So it's joining, eventually it's going to join with this vessel to create the superior vena cava, which is why you can see it as a loop. Okay, does anyone know what this vessel is?
Is it the right brachiocephalic trunk?
Yes, it is. Nice. And does anyone know what these two branches are?
The left subclavian and the left brachiocephalic. The left subclavian, left common carotid.
Yes, yes.
Yes.
Nice. So this is the labeled version. The left brachiocephalic vein, the right brachiocephalic vein, the trachea and esophagus, and the three main branches, which is the right brachiocephalic trunk, the left common carotid, and the left subclavian. Now, this level is T3. So again, we can see the trachea, so now we know we're above T4. And we can see the main branches and the main vessels, which we know is supposed to be at level T3. Okay.
So that would be the superior mediastinum?
Yes, yes, because again, we're above T4. So we're still in the superior mediastinum. Yes.
Okay.
And this is another image, same image, just done with a different, just showing you radiographic image instead of a cross section. So we can see again the trachea, esophagus, the three main branches, left brachiocephalic and the right brachiocephalic vein. Okay. Now the next section we were above here initially, which is at level T3, and now we're going a lot lower. We're going to be seeing the superior vena cava, and we're going to see the arch of aorta. And let's see what else we can see. So when we look at this image, we first always identify this structure here. So the trachea and esophagus again. So now we know we're still above T4 because we said anything below T4, we won't see the trachea anymore. So the trachea, if you see one tube, it's above T4. If you see two, then it's below T4. Now, what else do you see? Does anyone know what the structure is?
Is this the superior vena cava?
Yes. So this is a superior vena cava where I'm marking my cursor, and it's still getting the branch of the left brachiocephalic vein. So this is the structure of the superior vena cava, and it's just cut off right before it's getting the supply of the left brachiocephalic. Does anyone know what this vessel right here is?
It's the arch of the aorta.
Yes, yes. So this is the arch of aorta, and you can't see the three branches we just saw. So again, this is above T4, and these are all the branches and all the identifying things to identify. Now, moving on, we're gonna look at T4, T5. We're gonna see this little vessel here. Does anyone know what this vessel is, or can kind of guess what it is? So this vessel right here is the azygous vein, and we're going to see it in the cross section. Now, in this cross section, always again, identify the trachea and the esophagus. So we can see the esophagus here, but I want to make a distinction. The trachea right here, does everyone notice how it's slowly bifurcating? So this is the point of bifurcation, okay? So it's not fully separated yet. However, we just captured the cross section right before the entire bifurcation of the trachea. So now we know that we're below T4. Okay. Second of all, we can see the structure right here. Does anyone know what this is?
The superior vena cava.
Yes. And it has something draining into it. What would that be?
Azygous vein.
Yes. So does anyone know where the origin of the azygous vein is? So I can see this connection. This is the superior vena cava. This is the drainage of the azygous vein. Where is the actual azygous vein? Well, if you guys can see right here, this small connection, this is the azygous vein. And you can see it's open to the connection with the superior vena cava. So this is the drainage or the arch of the azygous. It's connecting the azygous vein to the superior vena cava. Is that very clear?
Yes.
Okay, and the reason why I'm saying this and emphasizing on this is because you will see the azygous vein in the next few images, but you won't see the arch of azygous. So you can still identify the azygous even without the arch. However, it's it's a lot easier to identify with the arch available. Second of all, we have two very large vessels over here. Does anyone know what they are?
The ascending and descending aorta.
Which is which?
The one marked with blue is the ascending, and the one posterior is the descending.
Excellent. Okay. Yep. So again, this is the superior vena cava. This is the azygous arch. This is the azygous vein. And we can see the ascending and descending aorta. And this is approximately between T4 and T5. Now, for the next cross section, we're going to be going even lower. So if you guys can see what exactly we're seeing, just to give you an image, we're going to be crossing, okay, through the pulmonary trunk, through the aorta, and through the superior vena cava. So we should be seeing all three of these structures: pulmonary trunk, the aorta, and the superior vena cava. Okay. So again, as previous images we saw, this is ascending aorta and descending aorta. This, does anyone know what this is?
Esophagus.
Yes. What is this vessel right here?
Azygous.
Yes. See? So we just saw azygous being connected. So it's still the same connection, but it's still the same vessels, but just without the connection. Is that clear?
Yes.
Okay, nice. And does anyone see the trachea? No, we don't. Okay. Instead, we see these two. What are these?
The right and left principal bronchus.
Okay, so what does that tell us? Where are we?
Below T4.
Excellent. Okay. So I want to make this very clear. Anything, it's very easy to identify. So the most important thing when you're looking at cross-section is to try to get a grasp of where you are first before identifying structures. So if I know I'm below T4, I don't see the trachea, it makes my whole life a lot easier. You can identify everything very easy. So I see no trachea, I see the right and left main bronchus, I know for a fact I'm below T4. And then from there on, I can identify other structures. Okay. And then we said this is the SVC, this is ascending and descending aorta. What is this structure right here? And its connection.
Pulmonary trunk.
And what is it giving?
It's giving the pulmonary arteries. The
Which
right.
one right now?
I think the right. The
No,
left pulmonary artery.
this is the left. Yes. Okay.
Mhm.
So we caught right before the bifurcation. So the bifurcation of the pulmonary trunk is at T5, we said, approximately. Okay. And you will see both vessels. So the pulmonary trunk first gives off the left pulmonary artery and then gives off the right pulmonary artery slightly below. And we'll see in the next picture. So this is the pulmonary trunk and this is the left pulmonary artery. Okay. Now we're going to go slightly below. Okay. We're still going to be at the level of T5. So before we were at T4 to T5, now we're going to be at T5 and we'll see the structures available. So as we said before, always orient yourself. Okay. So do I see a trachea? No, I see the left and right main bronchus and I see the esophagus. Okay. And I see the descending and ascending aorta. I see the superior vena cava and I see the azygous vein. Okay. So now I'm oriented. I know I'm below T4. I see the ascending, descending aorta, the esophagus, the two main bronchi. I identified most structures. Now I look at the unique structures of this cross section. I see the pulmonary trunk again, and now we see the bifurcation. So we can see the remnant of the left pulmonary artery, and now the new right pulmonary artery. So this is at the level of T5. Does anyone have any questions about the cross sections?
No.
Excellent.
I think we saw one before that had the left atrium, not here, but in the lab, I think.
Oh yes, we will cover that. Yes, we'll cover
Okay.
that. Okay. Okay, so in this picture right here, this image, we have an X-ray, of course. I want you guys to help me identify the cardiac silhouette and what makes each part of the silhouette. So if did Rawan cover this? Was this covered already?
She covered the borders, but we didn't take it on an X-ray.
Okay, sure. Okay, good. Can anyone tell me what structure makes this silhouette right here?
The right atrium.
Excellent. So when you say what makes the right cardiac silhouette, that is the right atrium. Excellent. And then we can see the right atrium is very obvious as a curve, and we can see a second curve. And what's the second? What is this structure right here? What makes this silhouette?
In the superior vena cava.
Excellent. Okay. Now moving on to the left side, we can see this very prominent notch. What would this be?
Aortic knuckle.
Perfect. And then we see this very large imprint. What would this be?
Left ventricle.
Excellent, excellent. Those are the main, silhouettes or borders of the silhouette. And you also have the inferior vena cava slightly. However, mainly this is the right atrium. And then you have the left prominent artery, which is not as prominent as the knuckle. Okay, those are less commonly asked, to be honest. But the main important ones: right atrium, superior vena cava, aortic knuckle, and the left ventricle. Okay. Now we move on to this. Does anyone know what this is called? This picture, this image.
An aortogram.
What is an aortogram? If you can explain that.
It's basically a dye that's inserted into the aorta, and it highlights all the arteries that comes out of it.
Perfect.
Like-
Yes. So they inject contrast and they take imaging, and this is what we call CT angiography. Okay, which is how you see vessels and their different blood supplies, and if see there's any occlusion. So anytime you have an occlusion, you want to do a CT angio to see which vessels are being occluded and how severe the occlusion is. So that's not really relevant for you guys occlusion-wise. However, you want to be able to identify the structures on a basic aortogram. Now, I'm going to ask a couple questions. I want you guys to answer which is which. So number one, what would number one be?
The ascending aorta.
Great. And what would number 8 be?
The vertebral artery.
Close, but look, number 8 is going where? Towards the brain. What artery goes to the brain?
Yeah, the common carotid, the right common carotid.
Yes. So you're close. The vertebral artery is number 9. So it's giving a branch right here. But this very large vessel is the right common carotid. Okay.
Okay.
Okay. What else? And number 3. What is number 3?
The descending aorta.
And lastly, number 6. What's number 6?
Left subclavian.
Okay, left subclavian. Yeah, that's right. Now moving on. Does anyone know what this image is called?
A bronchogram.
Nice. By the way, guys, if I'm going too slow or going too fast, just let me know, and I'll change the pace accordingly. Okay, so is my pace good, or should I be going a little faster? What do you guys think?
It's good.
Okay, good. I want to identify all these structures on this bronchogram. So number 1, what is number 1?
Trachea.
Nice. Okay. And then we can see number 2. What's number 2?
The left main bronchus.
Excellent. And the left main bronchus will divide into 4 and 5. What are 4 and 5?
The superior and inferior lobar bronchus.
Yes. Okay. Number 3. What's that?
The right principal bronchus.
Nice. And 6, 7, and 8?
The superior, middle, and inferior lobar bronchus. Yeah.
Okay. Yes. Now, this picture we've already covered, so let's see if you guys remember what we did. So we'll cover most of these. So does anyone know the number 7? What's number 7? Is it clear? Should I make it bigger for you guys?
Yeah, it's clear.
Okay. So can anyone answer?
It's the trachea.
Yes. Okay. So number 7 is trachea. So what's very clear about the trachea in comparison to the other things in this image?
It's black in color
Why is that?
because air appears black in
Yes.
CT scans.
Yes. So that's a very easy way to identify the trachea is because we can see the lungs are black, filled with air, and the trachea will be black, filled with air. However, all the vessels will not be black because they have no air, which would be very dangerous, to be honest. But yeah, they don't have air. So number 7, which is pitch black, is a trachea. Excellent. And what is number 13?
The right brachiocephalic vein.
Close.
I think brachiocephalic trunk.
Again, close, but not correct.
Oh no, brachiocephalic trunk would be 12, right?
Yes, yes.
Okay.
See, it's good to review. Yes. So number 12 is brachiocephalic trunk. What would 13 be?
Is it
Okay,
the
let's-
ascending?
Sorry?
Is it the ascending?
No, it would not be.
SVC.
Excellent. Who said that? Okay, that was a good answer. So,
Okay.
so why is this? Okay, so let's dissect this image so then we can understand where we are. So first of all, we can see the trachea, okay? So that means we are above T4. Okay? Okay, so above T4, you can see the esophagus with number 8. And we can see many vessels. When we see many vessels, we know that we're at the T3 level. If we remember before previously, the 3 branches of the aorta, okay, are coming at T3, as well as the superior vena cava. So we can see together there's 9. This altogether is the aortic, or the arch of aorta. Number 10 is the first branch, which is the left subclavian. Number 11 is the left common carotid. Number 12 is the brachiocephalic trunk. And number 13 is the superior vena cava. And we can see that it's getting a drainage from the left brachiocephalic vein. Is it clear for everyone?
Yes.
Okay. I think for these images, we'll first cover the what the structures are, and then we'll go back and try to test you guys. Okay. So now the X-ray in general. So when you're looking at X-ray, basic knowledge is to always start with the patient information. So if a doctor asks you to read an X-ray in front of you, what's the first thing you will do? I will first identify the patient. Because sometimes we make mistakes and we'll read an X-ray when it's not even for the patient that we're treating, which could be very fatal, especially when you're looking at different pathologies and different diseases in different patients. So it's very critical to identify the patient information, their name, MRN, all that stuff. This may not be relevant for you guys, but it's very good to keep in your mind whenever you're reading any imaging, because you want to have a sequence that you'll never forget. So once you learn the sequence, it'll be like muscle memory. So initially, I get an X-ray. First thing I do, patient information. Okay, excellent. What do I do after? There's different methods and different ways of reading an X-ray. Some people like the outside to inside method, which is where you look at what's most external or outer, any attachments. Does he have any ECG leads, any tubes, any structures going inside him? Because patients in the hospital will have chest tubes or nasogastric tubes in the stomach. Will have many different attachments to them, and you have to be able to identify them and say what they are and anything significant about them. So there's that method, which is going from outside to inside, and then the ABCD method. Now you can choose whatever you want, whatever suits whatever suits you. But it's very excellent and very important from very early on to know how to read an X-ray in sequence. Okay. So yeah, this is pretty much it for this slide. Again, the cardiac shadow is the most important thing. As remember, we talked about the right atrium and all the silhouettes of the heart and what it lines exactly. Okay. So again, the cardiac shadows we saw. So this is the right atrium, the superior vena cava, the aortic knob. As you said, the left pulmonary artery, you can slightly see it. It's not as significant though. And then you can see the left ventricle. Okay, and then we can see, I think mashallah, what's her name? Rawan already covered this, but again, the anterior border right behind the sternum will be the right ventricle. So every time, for example, a patient comes within a stab wound in the anterior midline of the chest, the most likely injured chamber of the heart will always be the left ventricle, okay? The inferior border is the left ventricle, you can see right here. And the posterior will be the left atrium. So again, it's very important to be able to orient yourself with these cross sections. Inshallah, it's been helpful. If anyone has any questions about the cross sections and how to identify them, please go ahead and ask. Inshallah, I've covered it well. If not, you can ask any question at all. Okay, so one of you guys has asked if we're gonna go over the cross section of the heart, and we will. So in this image, we can identify. First of all, we always orient ourselves. So it's very easy to orient yourself when you see a heart. When you see the heart, you know for sure you're in the inferior mediastinum, meaning you are below T4. Oh, that's for sure. And then you can identify very easily. We said the most anterior structure right behind the sternum will always be the right ventricle. So sometimes it's confusing whenever you have right and left, which is the ventricle, which is the right ventricle, which is the left ventricle. But it's very easy to orient yourself with this one point. What is the most anterior structure? The right ventricle. What is the most posterior structure? The left atrium. Okay. And then likewise, what's connected to each one? So the right ventricle will be connected to the right atrium. The left ventricle will be connected to the left atrium. So it's very easy to orient yourself. Next, this image right here is at a higher level than this image right here, because we can still see the ascending and descending aorta. Okay. Over here, we only saw the descending. There's no ascending. We saw the ascending and descending, and we saw the pulmonary arteries before. So the pulmonary arteries, which is dividing into the right and left pulmonary arteries. Is it clear for everyone?
Yes.
Okay. Yeah, so again, just reviewing, mashallah, you guys really knew what you guys were talking about. You guys, mashallah, reviewed well. So the structures of the aortogram are here to review, but mashallah, I think you guys are very good in them. So again, just quickly reviewing, this is ascending aorta, arch of aorta descending. Okay, the three main branches: left subclavian, left common carotid, brachiocephalic. Brachiocephalic trunk divides into the right common carotid, and the right subclavian. Okay. The right common carotid will give what we call a vertebral branch, okay, or vertebral artery, which will supply the vertebrae, of course. And then you have minimal branches, which you may review, but are very, less or high yield. Again, the bronchogram, mashallah, you guys knew it all. Is a trachea divided into the left and right main bronchus, and the left main bronchus is divided into two: the left superior lobar bronchus and the left inferior lower bronchus. And the right main bronchus is divided into three: superior, middle, and inferior lobar bronchus. Now, moving on from the mediastinum, does anyone have any questions from the mediastinum? You can go ahead and ask. Does anyone have any questions? Okay. So moving on to the nasal cavity, okay? So the nasal cavity is, we're going to first talk about the boundaries, okay? So look at the nasal cavity. The floor is the hard palate, okay? The roof will be the ethmoid bone along with the cribriform plate. We'll see the significance of this plate later on. Laterally, you're going to have the lateral walls, okay? And medially, you're going to have the nasal septum. In the nasal cavity, you're going to have what we call three concha, okay, which are bony structures, and we'll create what we call three separate meatises, and we'll see the significance of these meatises shortly. So the three conchas we can see right here, the superior, middle, and inferior conchas, create what we call meatises: superior, middle, and inferior meatus in yellow. Now, the significance of these meatises is the drainage of fluid. Okay, so these meatises are their function is to drain fluid from certain structures, and we'll find out what structures these are. So the superior meatus drains one single structure, which is the posterior ethmoidal sinus. Okay, the middle meatus will drain everything else, every other sinus. So the frontal sinus, the anterior ethmoidal, and the maxillary sinus. They will all drain into the middle meatus. And then you have the inferior meatus, okay, which will drain the nasolacrimal ducts, okay. And this is why if you ever experience, if you're crying a lot, you'll see that your nose becomes stuffy. This is the connection from your eyes, your nasolacrimal duct, your tears into the nasal cavity. So that will drain into the inferior meatus. Okay, so again, we can see the structures here. This was in your lab. We can see the three concha, superior, the middle concha, and the inferior concha. And in between, it creates little meatises. You can see the small pockets, you could say. This is the inferior meatus, middle, and superior. And then we can see here, this is the sphenoid sinus. This is incorrect. Sphenoid sinus. And this right here is the sphenoethmoidal recess. Okay. Another point is, does anyone know what nerve passes through the ethmoid bone?
The olfactory nerve.
Okay, yes. Excellent. What's the significance of this passage? What can happen? Okay, maybe this wasn't covered before, but an important thing to know is that people with any traumatic injury to the ethmoidal bone or any facial injury have an increased risk to experience anosmia, or they can't smell. So what's this reason? Is because the olfactory nerve is going through the ethmoidal bone. to the cribriform plate. And if there's damage to the bone itself, it can result in what we call avulsion of the olfactory nerve. So this will cause injury to the olfactory nerve, and they will lose their sense of smell, which is another word for anosmia. Okay, moving on to the larynx. Very shortly, there's 4 cartilages that make up the larynx: the cricoid, the thyroid cartilage, the corniculate, and the epiglottis. Okay. You can see the cricoid cartilage right here, very clearly. Now, we're going to talk about the vocal folds, okay? So the vocal cord specifically is inside the larynx. When the vocal ligament is covered by mucosa, that's what's called a vocal fold. That's the difference between a fold and the cord. Anteriorly will be the thyroid cartilage. So anything in front of this will be the thyroid cartilage. Posteriorly is attached to the arytenoid cartilage. The posterior cricoarytenoid muscle is what abducts the vocal fold. Okay. The cricothyroid muscle will tense the vocal folds by pulling the thyroid forward. So this is the cricothyroid, and this will essentially tense up this vocal cord and pull the thyroid forward. Okay. And what's the function of this? This is how you have a high pitch voice. So if you can increase the pitch of your voice, this is because the cricothyroid muscle is pulling and tensing up the vocal cords, okay? So very significant, this is very significant right here, is all the muscles in the larynx are supplied by one nerve, the recurrent laryngeal nerve, except the cricothyroid muscle, okay? So I have a question for you guys. What can happen if you have damage to the recurrent laryngeal nerve on one side?
Hoarseness of the voice.
And if you were to have injury on both sides, what would happen? You'd have paralysis.
Yeah.
Yes. So if only one side is affected, you're gonna have hoarseness. They can't talk. That's what hoarseness is. They cannot speak properly because only one side of the vocal cord is actually working and functioning. If they're both dysfunctional, that they have completely vocal cord paralysis, they cannot speak. But what happens if you have injury to the superior laryngeal nerve? Does anyone know what happens?
You get monotone voice.
Okay, so what do they mean by monotone? Like what specifically is lost?
The tone of the voice.
Yes. So what's lost is the high-pitched voice. So they can speak normally, you can hear them, they're perfectly fine. They cannot, however, have a high-pitched voice. They can't raise their voice, okay? The reason being is because the cricothyroid muscle is affected. Again, as we said, the cricothyroid, what it does is it tenses up the vocal cord, okay, by pulling the thyroid forward, and this will cause what we call high-pitched voice. So that's what they lose. That's why they sound monotone. They sound the same tone the whole time. They have the same tone. It's because they cannot increase their tone. Is that clear?
Yes.
Okay. Now moving on to the ECG lab. Okay. So we're gonna first of all compare diastolic and systolic on resting state ECG. We're gonna compare inhalation and exhalation. We're gonna see what happens on the ECG when you stand up and what happens when you exercise and recover. Okay. So in the resting ECG, what do we see? Okay. So systolic, the definition of systole, okay, is from the start of the QRS complex, okay, the start of it, until the peak of the T wave. Can anyone explain to me why is it specifically at this point? So why is it that we have to start from the QRS complex to the peak of the T wave? Why is this specifically systole?
Because the QRS complex denotes the contraction of the ventricle, and the T wave denotes the repolarization of the ventricle. So just at the beginning of T CVP is where it stops.
Very, very good, very good. So, as you said, the QRS complex is for ventricular depolarization. So we can't say contraction because all it's telling you is the electrical voltage. You know what I mean? So the correct answer is depolarization, but you're correct. It is the contraction of the ventricle, salah. But specifically, it's a depolarization. And then T wave is the repolarization, which is, so that's why systole is from the start of QRS to the middle, to the peak of the T wave. Diastole is from the peak of the T wave all the way to the peak of the next P wave. This is the diastole or relaxation of the ventricle. Okay. And again, normal heart rate is around 60 to 100. Hopefully you guys know that. And then we're going to see what's the effect of inhalation versus exhalation. So here we see the inhalation causes an increased heart rate. Does anyone know why this is?
To increase the cardiac output so that more pulmonary capillaries will have blood.
MashaAllah. Who said this? Excellent answer. Was this covered in your lectures or did you just know this yourself?
We took it in one of the pulmonary physiology lectures.
Okay, nice. Okay. I didn't know if it was covered. So mashallah, that's a very excellent point. So subhanAllah, what happens is when we're breathing in and out, subhanAllah, the lungs will send out signals. Okay, so this is called the respiratory reflex. Okay. So what happens is as the lungs are expanding, you're breathing in air, you're breathing in oxygen. The lungs want enough blood to be present in order to oxygenate it. So logically, so subhanAllah, when you expand the lungs, you're doing two things. First of all, you're creating increased negative pressure inside the thoracic cavity. So negative pressure causes what? Causes the blood to rush into the right atrium. Okay, is everyone with me so far?
Yes.
So the negative pressure, okay, it increases the amount of what we call venous return, okay, or preload, the amount of blood going into the right atrium. So it's gonna have a rush of blood into the right atrium, as well as an increased cardiac output as a result. And as your colleague said, mashallah, is because we want to have an increased cardiac output and an increased amount of blood going to the lungs as we're giving oxygen. So as we're breathing in oxygen, we want it to actually go to the blood. So we want as much blood as possible going to the lungs as we're breathing in. So that's why there's an increased heart rate. And then vice versa with exhalation. Okay, so we don't have any more oxygen. We're just breathing out carbon dioxide. There's no reason to have a lot of blood going to the lungs, correct? Which is why, subhanAllah, will have a decreased heart rate. Is that very clear for everyone?
Yes.
Yeah. Is this what's called sinus respiratory arrhythmia?
Yes, it is.
Okay.
And specifically, I didn't explain this. Specifically, how it functions is very, it's to do with the sympathetic versus parasympathetic, supply. So what happens is, as your colleague said, the respiratory reflex, what happens is, as we're breathing in, this sends signals to our brain to increase sympathetic output, okay? So as we increase sympathetic output, this will cause increased heart rate and increased cardiac output. And this is what allows an increased amount of blood to go to your lungs and allow it to be oxygenated, and vice versa. During exhalation, we don't need that much heart or that much blood going to the lungs. So the parasympathetic or the vagus nerve will increase firing, and this will cause a slowed heart rate. Okay. Now we'll talk about resting to standing ECG. Okay. So immediately after standing, the heart rate will increase to 115. Okay, so your heart rate increases. So what's the reason for this process? Does anyone know?
It's because of the baroreceptor reflex.
Excellent, excellent. So when you're standing up, what happens is, due to gravity, you're gonna have initially a drop in blood pressure. Okay, this drop in blood pressure will be sensed by your baroreceptors. Once they sense a decreased blood pressure, they will decrease firing. When a baroreceptor decreases firing, that means there's decreased parasympathetic. If there's decreased parasympathetic, that means there's increased sympathetic supply, and that will result in an increased heart rate. To allow to compensate for that fall in blood pressure, you want to compensate by increasing heart rate and bring that blood pressure back. Now for exercise, okay, exercise very simply. When you exercise, you need an increased amount of blood supply to your muscles. So as a result, we're going to have an increase in cardiac output and an increase in heart rate. Okay, moving on to histology, inshallah. I have some questions here in histology, so I want you guys to be more interactive in answering these questions, because histology is not much to explain, to be honest, but a lot of we can ask questions and answer them, inshallah. So for the first question, can we name or identify these two things, CC and GC? Can you guys identify what these are?
So GC are goblet cells. I'm not sure what's meant by CC.
CC, okay, good. Okay, so you said goblet cells, perfect answer. Does anyone have any idea what CC is or what it's kind of labeling?
Ciliated columnar cells.
Perfect. Can you just, one more word I'm looking for, ciliated something, columnar cells?
Pseudostratified.
Yes, perfect. So first question is, where are we? What structure is this? So what structure has ciliated, pseudostratified epithelium and goblet cells? What is that structure?
The nose?
And nasal cavity.
No. Pseudostratified and goblet cells. That is in the trachea. Okay, guys?
But trachea, you'd also see the cartilage, which we can't see.
Oh,
From
yes.
this-
This is specifically just the mucosa. But however, when you see the ciliated pseudostratified, most likely you will be at least the trachea or the bronchus. Do you get what I mean? Because the epithelium of the respiratory tract goes initially from the trachea. The trachea begins at ciliated pseudostratified columnar epithelium with goblet cells. And as you said, you're very correct. You'll have cartilage, and we'll see the cartilage in the next slides. However, the mucosa or the epithelium will go from ciliated pseudostratified columnar with goblet cells, and will slowly become, as you will see, simple cuboid. Okay, ciliated. So when I see pseudostratified columnar, I know that I'm very early on in the respiratory tract. So I know this should be the trachea or the bronchi. Does that make sense?
Yes, but why can't it be the side of the nasal cavity that has a respiratory epithelium, so not the olfactory parts?
Oh, that could be correct, yes.
Yeah, I think that's what me and my colleague meant.
Okay, no problem. That's fine. For this slide, does anyone know what this is? Can you identify 1 and 2?
Yeah, so this would be nasal cavity olfactory part. So olfactory epithelium.
Perfect. Olfactory epithelium. So number 1 would be the olfactory cells themselves, and this would be the lamina propria. Okay? Next, what are these two structures?
The trachea and esophagus.
Okay. And remember how before we talked about on the cross section how the trachea is much more circular anteriorly because of the cartilage, and it's very flat posteriorly because there's no cartilage posteriorly. We can see this very clearly. You see how thin the posterior side is and how thick the anterior is. So this is very clear that you can see the cartilage over here is anterior and it stops. There's no more cartilage. There's a very minimal amount of cartilage. And we can see the esophagus over here as well. Okay. Can someone first, before we start identifying 1, 2, 3, and 4, does anyone know where we are in the respiratory tract? Can anyone take a guess?
Bronchus.
Great. Okay, what makes you say that? Whoever said bronchus now has to say what 1, 2, 3, or 4 is.
We both said it, but I'll go ahead. We can see the cartilage and the lymphoid tissue, the bulk.
So which is which? I want numbers.
So 4 is cartilage and
Yes.
1 is bronchus lymphoid tissue, bronchus associated lymph tissue.
Perfect. And then we can see the epithelium, right? It's becoming more. What do you think the epithelium is here? What would you say?
It looks more cuboidal than columnar because of the circular nuclei.
Exact. Perfect. See? So we can just look at it and we can identify. So it looks to me that it's not pseudostratified, it's not columnar, it's getting slowly becoming more cuboid. We can see some are literally are a little elongated, but we can see most of them are very small and round. So now we can confirmly say, okay, the epithelium is slowly becoming simple cuboid. Okay. And number 3 is, of course, is the lamina propria.
The epithelium here is still ciliated, right?
It is still cilia. I'm saying slowly the transition is going, if you get what I mean. We can see there's a transition now.
And can we see the muscular tissue, or is it not clear?
And not in this cross section.
Okay, but we would expect to see muscular tissue in the bronchus.
Yes, you will.
Yeah.
Yes.
Okay.
But the main features are the cartilage and the bolt. Okay, those are the
Okay.
okay. Now for the one who asked before, this is the exact cross section I was talking about. So first of all, what is this organ we're looking at?
Trachea,
What makes you say that?
because we have hyaline cartilage
Perfect.
and it's very big.
Yes, perfect. That's exactly it. So whenever you see hyaline cartilage in this manner, mashallah, very dense, we know it's a trachea, most very likely. Okay. And we can see the mucosa, the submucosa, and you can see the adventitia. Clear?
Yes.
Okay. Now another question. Number 1, identify this part of the respiratory system. So what is this right here?
A bronchiole. A bronchus.
Bronchus. Excellent.
Yes.
Why is it a bronchus and not a bronchiole?
Because we can see cartilage, small parts of cartilage, and we can also see vault.
Perfect. Excellent. Now, the picture beside it, what is this one?
That's a bronchiole.
And
because we can't see anything, any cartilages.
yes.
Yeah.
Would this
Just
be? Do you think this would be small or large bronchiole? What do you think? You're right.
A large one.
What do you think it would be?
I think it would be a large one, a large bronchiole.
You're correct. Yes. So why? Because we can still see some ciliated pseudostratified epithelium. That's why. We can see goblet cells. So that's mainly why it's a large bronchiole. Okay.
So a small bronchiole wouldn't have goblet cells?
No, it wouldn't. So what happens is a small bronchiole will have no goblet cells. They'll instead have
Flower cells?
Flower cells. Yes, exactly.
Okay. And I just wanted to double check. A bronchiole has 2 layers of muscular tissue?
has two, sorry, say it again.
Does the bronchiole have 2 layers of muscular tissue?
That's a good question. I think I'll get back to you. Maybe one of your colleagues knows, but I'll have to check.
Okay.
Okay, next. Does anyone know what this structure is, what we're looking at?
Alveoli.
Perfect. And what is marked as X and what's marked as Y?
So X would be type 1 pneumocytes,
Nice.
and Y would be type 2 pneumocytes.
Perfect. Can you tell me the function of both?
So X makes up, it's elongated, so it makes up like most of the surface area of the alveoli. So its function is like the transport of gases. It's very
Yes.
thin, so.
Yes.
And
Excellent.
Y, it secretes surfactant. It's cuboidal in shape.
MashaAllah. Very good. Okay, so next picture right here. Does anyone can identify X for me?
I think it would be an alveolar duct.
Alveolar duct. Does anyone else have a different answer?
Or is it a small bronch? I don't know.
No, it's nice. Good answer. However, this was what we call a respiratory bronchiole. Have you
Okay,
heard of this
okay.
before?
Yeah.
Yes. So how
Yeah,
do we know?
so
It's a
would
respiratory
K
bronchiole?
be the duct then?
Yes, you're right.
Okay.
Yes. Is it clear?
Yeah.
See how difference in size, this difference in size is very clear, right?
Yeah.
Oh, yes.
Also, I went back to there was a document shared with us before, and I think it was the segmental bronchus that has 2 layers of muscle.
Okay. This is from your documents? You went back and saw it?
Yeah, this was a document shared in the lab.
Okay. So segmental has 2 layers of muscle. Okay.
Yeah.
Nice. Now, last slide, inshallah. Does anyone know what K is specifically?
Are these chlorella cells?
No, they're not.
Okay.
Nice try, but it's not.
Is it a macrophage?
Yes, very nice. So okay, so where can you find, it says, where can you find K? Where would you usually find these macrophages? Usually you'll find them in the septum, okay, the alveolar septum. So in between the alveoli. And you can also see them sometimes lining the alveoli themselves. So you can see in this green arrow, between alveoli, right? It's not lining an alveoli. Here, it could be lining a little bit. Does that make sense?
So does that mean the way to differentiate between macrophages and type 2 cells is that we'll usually find macrophages in the septum?
Well, let's see the difference right here. So yes, that's correct. That's one way, but it's also the shape of the cell itself. Okay. So if you can see here, this is a type 2 pneumocyte. It has a very, large nucleus with a round, what we call round nucleus and prominent nucleoli. So it looks very dark. And the cytoplasm we can see is like vacuolated, what we call, is a very distinct shape to the cell. And we can see here, we can see that it's very roundish, the alveolar macrophage. We can see sometimes it has phagocytosed carbon or air. So it looks very round in shape, does not have a prominent nucleoli.
Okay.
Okay.
Yeah, okay, that's clear.
Now for the second image right here, what are these cells right here?
These would be simple squamous cells, the mesothelial cells.
Excellent, mashallah. So is this the visceral or parietal?
This would be the visceral,
Why?
because it's the visceral pleura is adherent to the lung,
Excellent,
while
excellent.
yeah.
Yes, okay, perfect. So my question for you guys is the mesothelial cells, okay? Which one secretes pleural fluid? Would it be the parietal one or the visceral?
Visceral.
No, it's actually the parietal.
Okay.
That's right. So the parietal pleura, it's responsible for secreting pleural fluid, which is lining the lungs, and also reabsorbing. So it will secrete and reabsorb. Does that make sense? Okay.
Yes.
Okay, excellent. Okay, guys. Alhamdulillah, that's the end of our session today. If you have any more questions, you can ask me right now in the chat, or you can take my information, inshallah, and if you want to ask me in private, that's also okay. Both me and Rawan have put our emails and our numbers here. Thank you very much for listening to our talk. Hopefully we didn't bore you guys too much, inshallah, and hopefully you guys learned a lot. Does anyone have any questions?
I just want to ask them, sorry, Mu asked them, tell them, one person, I forgot who their name was, but they asked about the pectinate muscle and its function in the atrium. Was it one of
Yes.
you guys?
Yeah,
Yeah.
I'm here.
So I checked, and it's basically, yeah, like I said, the pectinate muscle in the right atrium, it's related to the volume. So it's basically to accommodate the changing volume status in the right atrium. Okay. But it's not like the trabecular corneae in the ventricle. Okay. So the function is different. The pectinate muscle, like I said, is for accommodating the constantly changing volume status of the right atrium, while the trabecular corneae, its function isn't really like well established. But some sources say, it's to prevent suction of the like blood, since that would happen if the wall was smooth. And others say, it helps with pumping ability and helping the papillary muscles keep the valves closed to heck. But yeah, that's what I
Okay.
found. Yeah.
Yeah. Okay. Thank you.
No problem. Anytime. Well, yeah, like Abdulaziz said, if you guys have any questions, Adi, let us know. Thank you for listening.
Thank you.
Yeah, thank you all. This was very helpful.
Thank you so much for this session.
Our pleasure. Hopefully you guys enjoyed, inshallah.
Yeah, also thanks to the host.
Excellent.